I think between the tumor-based methods, which test more genes, and liquid biopsy-based methods would help us in patients for which they have difficult to access tumors because of where their cancer is located, or for patients who develop resistance to targeted therapy. I think liquid biopsies are particularly important in that setting.
The thing we don't talk about all the time is how tricky it is to get genomics. How often do we meet a patient and we aren't sure of their genotype? We have tried to get tissue, we have tried to get results for them, and it hasn't panned out. And these are patients who maybe have a tumor specimen at diagnosis that's too small, and it's been exhausted just figuring out what kind of cancer it is. Maybe they have a hard to biopsy lesion that's in the bone primarily or in the brain. Or maybe you've gotten the tissue and it's just necrotic and it's fallen apart and it doesn't produce the results you want. And so I routinely see patients where I need a result today and the tissue I have available is not adequate for getting me genotyping. And that's where I think about liquid biopsies or a non-invasive testing as an alternative to tumor genotyping, trying to get me that genotype and get targeted therapy options for a patient.
One of the ways we utilize whole exome sequencing in an academic medical center is actually for cell therapy-based approaches. If we're trying to determine which specific T cell population to amplify for what we call TIL therapy or tumor-infiltrating lymphocyte therapy, we need both the exome to look at all the mutations that the cancer has, as well as to find the patient's HLA type, so we can engineer a specific cellular product for that specific patient. So I think beyond that unique clinical context, or a patient who's a never smoker, who has non-small cell lung cancer for which even a 400 gene panel did not detect a driver mutation, I think these are two scenarios in which we may consider a whole exome-based sequencing strategy, which typically is done in academic medical centers and likely not currently of immediate use in a community setting, at least at the current time. However, the 300 to 400 gene tumor-based NGS panels, I think in particular, are likely to be beneficial even in the community setting. And the liquid biopsy approaches for which we have 60 to 70 plus gene panels, I think may be of utility also in the community setting as well as in the academic setting as well.
When I'm thinking about who to send a liquid biopsy on, the question I am thinking for an individual patient is, does their cancer shed DNA? We are looking for DNA that is effectively the needle in the haystack being all of the patient's germline DNA, the needle being the tumor DNA floating around there. And there are certain characteristics that are associated with DNA shed. What we found in our studies so far is the more metastatic sites of disease they have, the more DNA shed. If they have liver or bone mets, more shed of DNA. Versus if this is a lung cancer patient with small lung nodules, asymptomatic, the chance of that being a shedding cancer with a productive liquid biopsy is smaller. And so this is something we each need to really develop a sense about as clinicians, which is in which patients is this tending to be a useful assay, and in which patients is this negative and falsely negative because there was simply no DNA in the specimen for us to assess. If you think about a biopsy, there was a pathologist looking at that specimen telling you, yep, it's got tumor in it, this is a good one for testing. But when you do a blood test, there is no one telling you, we've got good tumor DNA, this is adequate. And so you have to sort of trust, is this a cancer that's shedding DNA? Because if it's negative, you're falling back on tissue testing, the standard, as our backup test because sensitivity is not perfect with these assays.